4 points must be discussed as emergent infection in the elderly. The first one is that elderly population by itself is an emergent population because she is increasing a lot. And we have 2 types of old patients, old people, those who are traveling and they are exposed to new infection for them. I can think to dengue or chikungunya, naturally also tropical diseases. But the second one, or the second extreme, is for the very elderly. They are living in long-term care facilities. They will end their life in these facilities, and they are exposed to very, very resistant bacteria. The main examples are extended spectrum beta-lactamases, such as Escherichia coli. And we also have more and more carbapenem resistant bacteria. So they are exposed not to new agents, but to new resistant bacteria. And naturally, these whole people can also have this sort of bacteria in the community, mainly for urinary infection. The second point is that adult people with infections such as HIV are living older. And today, it's not rare to have people more than 70 years with HIV infection. HIV infection in old people is very specific because of the risk of dementia, the risk of cardiovascular diseases, and also with the difficulties with the drug-to-drug interactions, because those people have already different drugs for cardiovascular disease and so on. And we have to keep in mind that HIV infection can be acquired during adulthood, but also at the late stage of the adulthood. So we have, and the geriatrician have to have this disease in perspective. The third point I would like to discuss is the shift of the epidemiology. By shift of epidemiology, we have a very good example with whooping cough. Today, the reservoir of Bordetella pertussis is no more the infant, it's in the adult. And with the cocooning strategy of vaccination, we can probably have more cases in the oldest people more than 65 years old. We already have had epidemic in the situation of healthcare facilities, and the patients with whooping cough in these cases are very frail persons, and they can have complications such as rib fracture and also neurological complication. And to a less extent, we also have an impact of the vaccination of the youngest with pneumococcal conjugated vaccine. We have a seroreplacement, and we don't really know what will be the serotypes in the future. But what we know is that the strep pneumoniae are not all the same, and we could have such as opportunistic infection in the elderly because they are frail and they can be infected by lower pathogen strep pneumoniae, but with different types of diseases. And the fourth point I would like to discuss is Clostridium difficile. Clostridium difficile is a more and more frequent disease in the oldest, and with a prognostic which is better in the older than in the youngest people. I mean, it is 13% risk of death for this population. And they are exposed by different reasons, because they have comorbidities, and also because you are more often hospitalized than the youngest people because of such disease like cancer, or they also receive different course of antibiotics. So in conclusion, we have more and more old and very old people. They are exposed to sort of nosocomial infection with very resistant bacteria, exposed to new bacteria for them. And we have to keep in mind that it is very important to have this knowledge in our mind when we are diagnosing or taking care for those patients. Thank you very much.